With us Dr. ANIKET Shastri from Joshi High Hospital, a highly proficient surgeon and consultant ophthalmologist there. And he has a wonderful pearl of wisdom for us. On to you, Dr. ANIKET.
Thank you so much, Chitra ma'am, for this opportunity. I want to thank the ARC also for this opportunity. I'll start sharing my screen now. Is visible?
Yeah. Yeah.
So this is a case.
No, you're okay.
So I'll just start from the beginning. Yeah. So this is a case of traumatic subluxated cataract with traumatic mydriasis. So we planned a cataract extraction with CTR with aniridia IOL. Here we are making a superior corneoscleral tunnel. Now, because this was done during the lockdown, we didn't have a CTR based prosthetic iris device so that we can use a smaller tunnel. We had only this the iris lens implant. That is why we made a larger tunnel. And here we can clearly see the subluxation there. And 4 side ports were made, 2 for instrumentation and 2 small stab incisions here for the insertion of capsular hooks. Then we made a 2.8 mm temporal main incision. Then we used a 26 gauge cannula here. We thought the lens is quite intumescent. So an intracapsulotomy was performed with it and aspirated some of the cortical fluid to reduce the intralenticular pressure. The capsularesis here was initiated with the capsularesis forceps, and it was initiated the size of intact zonules. It's important to start at the place where there are zonules are intact because we don't want to stress more on the zonules that are already dehiscent. Then gradually progress circumferentially, and the area of the zonular dehiscence was approached at the end. It is important in cases of subluxation to perform a good hydrodissection and hydrodelineation. So the lens rotates freely and it helps you in phacoemulsification. Then the capsular hooks were inserted in the area of zonular dehiscence here to stabilize the bag. The hooks actually advantage over iris hooks here is it supports from the equator and causes less damage to the margins of the rexus. So after confirming that there was no vitreous in AC, we started with the phacoemulsification. Direct chop method was preferred as it causes less stress on the zonules during emulsification. And it was broken down into small pieces. This is fast forwarded for the sake of time. And then important thing is a regular injection of viscoelastics in between so that we flatten the posterior chamber and keep the bags inflated. Secondary capsular rexus was performed, as Anaga madam had said, to achieve an adequate size rexus so that we could put a large IOL implant there. And after this, bimanual IA was done to remove some of the small tags. As the zonular dehiscence here was less than 3 clock hours and it was temporal, we planned a CTR insertion to fix the bag, and the CTR here was inserted manually. It was entered from a side port opposite the area of zonular dehiscence, so that when it enters the bag, it first stabilizes the part of the zonular dehiscence, and then once that is done, then it is gradually rotated into the bag. And now it was gradually rotated then into the bag, slightly slipped. This here there could be some trouble sometimes. And then once the bag was fixed, then the capsular hooks were removed gently. And then because it was the only thing that was available with us during that time, an aniridia IOL, it was implanted there. Once we opened the sclerocorneal tunnel. And one thing to remember here is that to place the haptics in the area where the zonulas are intact and avoid the area of zonular dehiscence. So when that was done, then we, because of the traumatic cataract, I usually suture my tunnels, and because it's a larger tunnel also required for such large IOLs, the conjunctiva was closed. And this is a rough guide for the choice of back fixation with respect to the extent of zonular dehiscence. So I'd like to thank my guru, Dr. K.V. Satyamurthy sir, for guiding me always through such tough cases. Thank you so much.
Thank you very much, Dr. ANIKET. That was a lot of learning tips in this video. Some of the queries which I have is, I understand because you have to place the annularity IOL, you have to make your CCC in the area of zonular weakness. So how did you manage the vitreous not coming in when you're taking your instrument in and out in that area of zonular dialysis?
Actually,
then the second question is, I think all of us, at least I would do it, and I'm sure most of us do, that CTR haptic, I would always use take an instrument from the side port and tuck it into the capsular bag. And otherwise, sometimes it can go into the angle and it will not circularize the bag at all.
Agree,
and you did not use tricot.
Yes, ma'am. Actually, that's what the vitreous, just before starting the phacoemulsification, we found out, I mean, once we confirmed that there's no vitreous, then only we started. For the time frame, actually, there's so many points to cover. So for 4 minutes video, I had to cut short many things. The thing is, in between the surgery, we had to insert viscoelastics a lot of time. In fact, after every step, between every steps, we had to insert the viscoelastics continuously throughout so that we can maintain that chamber throughout, make it flat as much as possible and avoid the vitreous prolapse from that area. And one more point, which probably on retrospective, if I think what I would have done is, as soon as I started the procedure, I would have probably used a high viscoelastic, like a viscoat or something, so that or a hyal or something at the area of zonular dehiscence to push as much as vitreous behind, and then slowly done rest of the procedures.
Yeah. And you made such a large incision. What was the final visual outcome?
Ma'am, the visual outcome, the patient was in the range of around 6-12. He had some amount of posterior segment macular edema actually. But otherwise, costmaker, the main problem he came to us was whitening. Actually, he had trauma some time back. He never bothered. Now that it became white, he came to us stating that his eye had become white. And with that implant in place, he was quite happy with his cosmesis. Some amount of vision also is happy. We are managing the corneal edema.
So expert panel, generally I'm asking you all, you have anything to add in this case?
I was just thinking, Chitra, that for all the video submissions now you must put this thing on it, please use tricot and send your videos only with the tricot. Don't send them without the tricot.
I think Partha's insistent on tricot has rubbed on to Chitra. In court martial, he would always say, why
always. Yeah. No. I actually am so bothered that I should maximize learning in this particular session. Yeah.
So, ANIKET, which analytic lens did you use? Is it from Morcher or a local company?
The local company, sir. I think just get it from the store. Actually, implants we couldn't get any time during that period of.
From Care also makes.
So the only thing is that I don't know how many of you have a long-term experience. The pigment that is there leaches out in some of these local manufacturers. So be very careful and look at the pressure, because that also causes a trabeculitis and an increase in the pressure in such cases. And Morcher does not do that. I don't have any financial interest in that, but I have had my fingers burnt. So I haven't used them. I used them few years ago. That was just an analytic rig segment. So just be very careful that I have been closely watching that case. The pigment has actually leached out. That in itself is an art, to have it remain black throughout. So that is why the cost is very high. So just be a little watchful over the couple of years and see how it is.
Sure, sir. Sure.
Yeah. So we have 2 more speakers. So let's move on. Thanks a lot, ANIKET. That was a great